clinical practice outcomes stream at SNOMED CT Expo 2025. Thank you to FAST for sponsoring this stream. My name is Liara Tatina. I'm the Customers Relation Executive for Asia and Pacific and Global Education Lead at SNOMED International. I'll be your moderator for today. We'll address all questions at the end of the presentation. For our online audience, please use the Q&A button to submit your questions to the presenter. For those attending in person, feel free to use the microphone in the middle of the room when the time comes. It's now my pleasure to introduce Concetta Piazzese from Barts Health NHS Trust and Queen Mary University, who will be presenting a SNOMED-driven clinical dashboard system to support the identification and management of diabetic patients with possible foot disease in a large academic health system in East London. Concetta, over to you.
Thank you so much. Good morning, everyone. First of all, thank you so much for giving me the opportunity to present this work. It's a pleasure to be here. My name is Concetta. I'm a senior data engineer for Barts Life Science. So Barts Life Science is a partnership between Barts Health NHS Trust and Queen Mary. I specifically work in a team of data scientists where we support clinicians in the trust with any type of research projects in order to bring innovation into the trust. So what we do is not just stopping, for example, when there is the publication of a paper, but we still move on and we try to deploy the tool in the trust because we want to really make an impact to change the pathway of the patient, so to improve healthcare in our hospitals. Specifically, Barts Health NHS Trust is a big trust in the UK. It's made up of 5 hospitals in northeast London, and we basically have a population of over 2 million of residents. I'm not going through details, but as you can see by the numbers, there is a large activity happening in all our hospitals, and basically, as you can see at the bottom on the right-hand side, we see more or less 7,000 patients per day all over our hospitals. So there is a large activity, there is a lot of data, a lot is happening, a lot of reports, a lot of documents, so a lot of things that we can do with all this data. It was noted that in northeast London, diabetes has a high prevalence, and this is because there is a young transient population, there is diverse ethnicity, or there is also unequal access to care. So complication screening for diabetes are challenging, and if someone with diabetes or diabetic foot is not screened in time, this can lead to really bad consequences, like the leg amputation. So we don't want to arrive to the point where it's too late and we have basically to amputate the leg, but we want to try to improve the screening so that we can identify these patients before and in time to provide them the care that they need. And usually what happens is when someone with the foot ulceration is identified, this should be urgently referred to the diabetic foot team to be assessed and to be given the right care. Oh, sorry, I think I skipped one. I think there is one slide missing in here. Sorry, that's fine. So this is just the current best practice according to the NICE guidance. So as you can see, what should happen in our trust is that, or in every hospital, is that there should be a screening for diabetes, and then there should be an assessment to check whether or not the patient has a possible foot complication. And then if this is suspected of happening, this should be referred to the multidisciplinary diabetic foot team within 24 hours, and within 48 hours, this patient should be actually reviewed by an appropriate specialist. And if this is all confirmed and the diagnosis is confirmed, the patient should be basically under the management then of the diabetic foot. However, the problem that we have is that these 3 points are not always happening. So there is a lot that is missing. So the screening is not really picking up the patients. So what we wanted to do was to try to act on these 3 points so that we can help somehow this screening of patients. And what we wanted to do was to basically use an AI model to help screening these patients by just using the reports that are created for the patients. And as I mentioned before, there is a lot of data in our trust, so a lot of data that can be used in order to accomplish that. And then we use this AI tool. The AI tool is reviewing the reports, a diagnosis or a flagging of the patients basically is provided, and then a podiatrist is then actually reviewing this and then is deciding whether or not the patient should be referred for an assessment of the foot. So as you can see, the model is not really providing a diagnosis. The model is helping with the screening of the patients, because at the end of the day, the action whether or not the patient should be referred to the diabetic foot team is made by a podiatrist. So as I mentioned before, the aim of the project that I'm going to present is to develop this tool that is going to help us identify patients. The pipeline is pretty simple. A patient is admitted in the trust. Within 24 hours, the reports of the patients are basically reviewed by an AI model. And then the AI model is providing some results. And then these results are reviewed by a podiatrist. And then an action is made on the judgment of the podiatrist. So I'm going to talk now about all the stages of the pipeline. So the first bit is the data extraction. So what we wanted to include, given that the model was running every day, was any patient that was coming into the trust that was admitted into the trust, in the previous 24 hours or 72 hours if it was the weekend, because we wanted to cover for Saturday and Sundays. And then we also excluded some type of documents, like, for example, maternity documents, just because we know that if someone is pregnant, it's very likely that they will develop diabetes. So in this case, we are not interested in this population. And then we also noticed that somehow this was triggering our model in the wrong way. So we decided to exclude any document coming from the maternity department, and also some coding summary documents that are just documents created by the finance team for billing purposes. So in that document, there is not anything new that has been already written in the reports written by clinicians. And also, we also excluded patients that were coming into the trust for a day case activity, because they basically were discharged, so it was difficult for us to follow up with those patients. So from this population, whether or not, when we identified those patients, we basically, for each patient, we extracted all the records that were available in our trust for the past 6 months. And also we extracted other clinical information like word, sex, ethnicity, gender, etc. And then phase 2 of the pipeline, all this data, we are talking about thousands of data. Usually every day, I think I had more than 40,000 reports that were fed into the model. So this data was giving us an input to a model. The model that we used is a model provided by a commercial company called Clinithink. The model has the ability to transform unstructured tests to structured tests. So it means that the model was able to map words that were in the reports to SNOMED codes. And then based on some queries that we developed, and I'm going to talk about in the next slides, we basically were able to identify the population and the cohort we were looking for. So again, we didn't have access to how the model was mapping the words into SNOMED codes, because again, it was a commercial company and they didn't actually release that to us. But what we could do was to develop the queries that the model was then using to basically filter the structured reports based on what we were looking for. So what we did was to develop queries, atomic queries. We added the temporal and contextual filters, and also we use the expression constrained language logic, so to make sure that we were identifying the population. And on the right-hand side, you can see basically what we did. So from the whole cohort of patients that we had, we were looking first at everyone who had diabetes. Then if the patient was having diabetes, he was going into this subpopulation that was further filtered. And then we basically then filtered again by checking whether or not the patient had mild or severe diabetic foot. So for the first stage, where we filtered the patients to check whether or not they had diabetes mellitus, what we did was to develop a series of queries. This is the table of the queries. I'm not sure if you can see all of that. Yeah, I think so. So, for example, the first one, diabetes mellitus not GD, is basically looking at patients with diabetes mellitus, but we are excluding gestational diabetes or borderline diabetes. You might ask, but you told us before that you already excluded the maternity documents. Yes, indeed we did, but somehow some reports were not coming with a label. So we had we noticed that sometimes some reports coming from the maternity department were not properly labeled, so somehow they were still ending up being processed by our model. So to make sure that those reports were not there, we decided to also exclude even more gestational diabetes. And other queries, for example, diabetic complication, unstable diabetes, HbA1c. So I'm not going through all of that, but to give you an example of the first one. So this is the ECL that we used for try to detect, for the first query, the diabetes mellitus. So in this case, we were looking for diabetes mellitus. As you can see, there are temporal and contextual filters. There is our SNOMED code for diabetes mellitus, but also we also excluded the gestational diabetes and borderline diabetes, still using SNOMED codes. And then for the second phase, where we already have the population of patients with diabetes that we want to further filter based on whether they have mild or severe diabetic foot. For mild diabetic foot, basically, we included everyone with diabetes mellitus plus any of the following that might be food disorder or abnormal food finding. So for example, below you can see food disorder, similar to what we saw before. It's a query with SNOMED concepts and contextual and temporal filters. One thing that I didn't mention is that Clinithink by default is including the children of the main code. So in this case, when we basically included the SNOMED code for food disorder, we were also including all the children that you see on the right, even if we didn't specify that in the query. And then the other filtering, severe diabetic foot, similar to what we saw before, people with diabetes, but plus any of the following. And we are going for any diabetic foot condition, foot ulcer, debridement, and so on. So I'm not going through all of this, but you now should have an idea of how each of these queries basically work. So putting all of this together, the model is basically mapping the word in the reports to SNOMED codes, and then is using our queries to identify the population, and then is providing us some results. These results are then collected and then are showed into a dashboard that is written in Python. So the dashboard is connecting automatically to the model and is retrieving the data. Anyone who wants to have a look at the dashboard has to basically there is a secure logging in, so it's not accessible to everyone. We provide the username and password just because we provide confidential information into the dashboard, so we want to make sure that only people we know that they should access are actually accessing the dashboard. The dashboard is customizable, as in like you can really change the plots that you're seeing depending on the categories that you want to show. Unfortunately, in the sake of time, I cannot give you really a demo, but happy to do that later if anyone is interested. But yeah, at the end of the day, the dashboard is presenting demographic information, risk assessment data coming in from the model, but also is presenting the free text nodes from the model with the concept that were triggering the model. And this was very useful because you could really see what SNOMED concept actually really triggered the model to say, oh, this patient has diabetic foot. So that was basically the pipeline. We tested the pipeline for 2 months, go from mid-January till mid-March 2025. The pipeline was running every day, and then it was providing results, and then a podiatrist and a consultant were reviewing the dashboard the day after. So the pipeline was running at 8 p.m. or, I don't know, on a Monday. Tuesday morning, podiatrist and consultant were reviewing the results and providing feedback. The difference between what the podiatrist and the consultant were seeing was that the podiatrist was just seeing what was available in the dashboard. So what I told you before about demographic, risk assessment data, and just the reports that were triggering the model, while the consultant had access to all the documents that were for all the patients that were basically fed into the model. So he had really an overview of all the reports that were used by the model to make the decision. Whether or not the model used that to make a decision, the consultant also had access to that as well. And then both the podiatrist and consultant were giving us a classification whether or not the patient was correctly or incorrectly classified by the model. So over 2 months, the model flagged 87 patients, 80% identified, classified with mild diabetic foot, 20% classified with severe diabetic foot. Among all these, 8 patients were known to the diabetic foot team. So we are happy that the model is actually confirming that some patients that are coming to trust knowing to the diabetic foot team are actually identified by the model. Most patients had an HbA1c test results, which most of the times was helpful to filter patients to say whether or not they had diabetes. Over the 87 patients, we know that for one patient, the podiatrist, after reviewing the dashboard, they decided to basically add a review of the foot for that specific patient because what he saw was like really severe, and they decided to do a foot check. And actually, at the end of the day, it was found out that actually that patient really had diabetic foot and is now under the care of the diabetic foot team. So that is a case where the patient was missed, the model identified the patient, and actually now the patient is receiving the care that they need to have for the condition that they have. Going back to what the podiatrist and consultant were seeing, as you can see, they were seeing different versions of the results. There was basically a good agreement between the two. So at the end of the day, whether or not you just see the dashboard or all the reports, it doesn't really matter. So even just seeing let's say the short version of the reports was good enough. And we decided to use the consultant as a baseline, as a ground truth, to check whether or not the model made the right classification for all of the 87 patients. So we basically achieved a precision, the model achieved a precision of 66%. So 57 were true positive, correctly identified, 30 unfortunately were false positives. And the main reasons that we found out of this happening was that the model was not really good in handling acronyms. As in, we got a lot of cases where we had radiology reports that were signed by someone whose initials were DF. So the model thought that DF was basically standing for diabetic foot. So in that case, it was an X-ray of the foot signed by DF, yes, diabetic foot, but no. So unfortunately, this is not something we can adjust with the queries. This is something that the CliniThink has to adjust with the way the model is mapping words in the text to SNOMED codes, and we already provided them with this feedback. And then yeah, so to conclude this presentation, I just showed you a system that we developed where there is an automatic way of identifying patients at risk of diabetic foot. And we basically tested the system, and we achieved a precision. Sorry, there is a mistake here, should be 66%. And then the system is providing clear explanation on why each patient is flagged, because in the dashboard you can see the reports that really flagged the model with the correspondent SNOMED codes. And then we are working still on improving the classification. As I said, we provided feedback to CliniThink, especially for handling the acronyms in the report. And future works, of course, again, we still are working on improving the classification, but also we are thinking about bringing in an open source model rather than using a commercial model, as it was mentioned in one of the previous presentations. Because again, not having full control of what we were doing was really challenging. Even developing the API to talk to the model was a little bit challenging, and that's because again it was a commercial company, so we didn't know what was happening there, but we just had to rely every time to the CliniThink team. And with that, I think that concludes my presentation. Thank you so much.
Thank you, Concetta. We will now move to question period. Those in the room who would like to ask a question, please use the microphone in the middle of the room. Okay, I have a question for you. How does the XLI-XNLP tool, or CliniThink, I would say, is a long name, right? Integrates with SNOMED CT to ensure accuracy when extracting relevant clinical terms? And how do you mitigate the false positives such as non-diabetic or congenital causes?
Yeah, I think for the accuracy, I think there are two things. So first of all is the mapping of the concept. And again, I have very little knowledge on how this is happening within CliniThink because they didn't actually release this to us. So we don't know how the model is mapping them. But as you can see, mapping them is the first stage to already moving from unstructured text to structured text that they are then filtered with our queries. So if there is already like something wrong happening at that stage, I'm afraid that will also be it will happen like also with the queries. For example, the acronym issue that we notice is something that we cannot control with the queries, but it's about the mapping. And then the other thing, of course, is to develop queries that are, that are good and that are good at identifying your cohort. This project actually started before I started working at BARTS, and the version of the queries that you see today is not the version that they had in 2021, because of course over time, by having this continuous iterative feedback by the podiatrist was helping us to improve the mapping of CliniThink, but also the queries that we developed. For the false positive, I would say that yes, the queries are the thing that you can use to improve that. For example, in one of the slides I showed you that we just didn't actually look for patients with diabetic foot, but we also looked for patients with diabetic foot, but we are excluding also some cases. So you don't just have to think about, oh, I want to look about this and this is what I need to do, but I want to look about this, but also what else should I exclude in order to make sure that everything I got is actually the right cohort that I'm looking for.
Great, thank you. We have a question in the room. If you could proceed to the middle of the room, there's like a microphone there. Thank you.
So thank you for a very clear presentation. It was very nice. What do you not use other criteria like to do queries? For example, if you have some diabetes complication like retinopathy, or you have a good chance to have also a diabetic foot. So you could enrich your system in adding some queries, I think. You think about that?
Yeah. I think, as I said, improving the queries, it's really important, and we are improving that over time. So any suggestion is all, of course, welcome. And we are working with a consultant and the podiatrist who basically are providing feedback to us on how we can basically improve the classification of the patients. Then whether or not this is a mapping problem or something that we can improve with our SNOMED queries is something that we basically decide case by case. But yeah, in general, every feedback we receive from the consultant and then the podiatrist, we take this in, and then we either provide this feedback to clinician if it's mapping, or we basically modify the queries if it's something that we can improve with the queries. But yeah, definitely.
So you had a vascular surgeon working with you.
Yeah.
And also a podiatry team.
Yeah.
Do you think you changed their behavior at all in recording SNOMED in the problem or procedure lists, or do you think they entirely depended on the free text interpretations?
I think that could help, because one thing, I didn't actually mention that, but one thing that we are also showing in the dashboard is, because our diabetic foot team is really good at basically adding SNOMED codes to reports. So we basically know, we can basically identify patients that have already been seen the diabetic foot team, because they are really good in providing SNOMED codes. So yes, that definitely would improve that, because one thing that we do now is we basically identify the patients, and then among the patients we identified, we can say, oh, this patient is already known to the diabetic foot team by just checking whether or not the SNOMED code is linked with the patients. And then in our basically testing, among all the 87 patients, we had patients that were already known to the diabetic foot team, and we basically knew that by just checking SNOMED codes associated with those patients. So yes, adding SNOMED codes really help.
Excellent. Thank you, Concetta, for an excellent presentation. And this concludes today's session for now. Thank you.
Thank you.